Optimal Bio podcast. At Optimal Bio, we don't just balance your hormones, we balance your whole body. Our conversations range from nutrition to medicine with an emphasis on wellness tips to support your health journey. If you like what you hear, find us on the web at optimalbio.com and follow the podcast so you don't miss an episode.
All right, welcome everybody to our first podcast in 2022 with Dr. Greg Brannon. How are you today, Greg?
Great, Jim. Fantastic. Thanks for asking.
You know, there's a couple things I want to go over today, and one's going to be a learning session for me and hopefully for our listeners as well, as we talk about peptides and we talk about CJC and the benefits of that. But also, I think one of the things that I think Optimal Bio and you in particular have revolutionized in the last couple of years is the actual BHRT pellet placement in both male and female. And I think that's somewhat overlooked at times. You know, obviously there's different types of testosterone treatments. And I want to go over, again, you know, shots and orals and all the positives and negatives to all those, and then to those, and then hopefully focus a little bit more about, you know, what we're doing here at Optimal Bio and you in particular, you know, that have helped, I think, almost eliminate, you know, any significant adverse events, you know, post-placement, you know, going forward. And it's something that I think you do with a lot of humility and we don't really talk about. So I thought today we would, you know, cover that because I do think that Optimal Bio is somewhat unique in that regard. Make sense?
Oh, thank you. Thank you, man. Appreciate it.
So why don't we just kind of give a, you know, testosterone one-on-one lesson and talk a little bit about the different treatment options that are out there these days, and kind of have you walk through the pros and cons of, you know, let's just start with the orals. You know, let's go, you know, I think we see some commercials these days with Roman and, you know, there's other providers that provide oral testosterone. So why don't we cover that first?
Yeah, first off is the route of administration is very important, but the first thing to understand is there is a low testosterone epidemic going. The range of testosterone 40, 50 years ago for an adult male was anywhere between 800 and 1400. Now, some universities have it 170 to 700. So we have to first recognize that there is a defect. And the reason why we're having a decrease, Dr. Traviston did a study where he looked at the last 5 decades, the last 50 years, average about 1% to 2% per year decline. With where we start, the initial starting point, let alone 1% or 2% per year we're losing. It has to do with because testosterone converts to estrogen in both men and women, which specifically talk about men right now. But estrogen is what's the rate limiter. That's the hormone that turns off the production of testosterone. So what happened in the last 50 years, we've been getting a lot of what's called neuroendocrine disruptors. And they're xenoestrogens. Xeno means foreign. So these foreign estrogens in our water and our fluid supply is tricking the body that we have enough estrogen, therefore we're not making the testosterone. So these levels, these ranges are correct for today, but they're not a healthy population base, number one. Then the next thing is, what's the best route to replace this? Well, you talk about oral. The first thing that's important to understand, the very first time testosterone was even isolated in human beings was 1931. The first paper ever showing pellets therapy given to a human being was in 1935 on women who had hysterectomies and replaced with testosterone and estrogen. Men was 1937. So we'll get to oral in a minute, Jim, but the first one was pellet. By 1947, they actually changed the structure. Natural testosterone called 17-beta testosterone. They made an oral version, 17-alpha methyl, and they gave that orally, and they found early as in the late 40s, it was increasing blood clots and possible cancer. So the route is very products that affect the liver. Then you had shots. They were done in the early 40s. Great way to go. There's an injection into the muscle, so there's a depot there. But the problem is the half-life is very fast, so there's peaks and valleys. And then the creams came out a little bit later that. Great again, but there's still peaks and valleys, and the skin does not act as a great entryway over time because it becomes not as efficient. So that's why we at Optimal Bio believe pellets are the best, because they mimic the testicle, the best thing out there. They have a nice steady state, and when the heart beats faster, you get a rise. So that's the best way to mimic our testicles as best as possible.
Okay, so you've covered 3 of the applications within the first 4 minutes of the podcast, but let's kind of go back.
We'll go more detail.
Let's go back. I appreciate the history lesson on testosterone. Why do people take orals? I mean, is it simply because it's easy to do? And, and then so that's one question. The second question is, from an efficacy standpoint, eliminating the adverse events you just spoke about a few minutes ago with the safety issues. Let's just talk about the efficacy of that.
Okay, there is no oral bioidentical testosterone. There are oral, like Anavar, oral synthetic anabolic steroids. Again, they're different. They do work, but they're different structure, therefore different potency, different metabolism, and different elimination. That's the complication problem. You want to have a hormone that's identified as same. That's what Mayo Clinic says. The definition of bioidentical is the body recognizes as same. Atom for atom, molecule for molecule, 3-dimensional structure for 3-dimensional structure. So therefore, how could you get that to the body? You can't do it taking the enterograph through the oral because, again, it won't be absorbed by the structure. You change the structure, increase blood clots through the liver. There are buccal amounts where you suck and let your inside your cheek can absorb it. Again, it does not reach peak levels. So, but when you take Anavar, it is oral, but it's not testosterone. It is a synthetic anabolic steroid that has great, we'll say, when you look at the outside effects of burning fat, building muscle, but it's not recognized the same in the body, so you don't have the same benefits of insulin resistance. You have the way you burn fat properly, but more importantly, at the metabolic level, it is throwing a monkey wrench into it. It's not working the way your body's supposed to work.
So if you were taking some of these synthetics, orals, and I was going to get a lab test and getting my testosterone checked on a regular basis, would my testosterone increase by taking these orals?
Your testosterone increase, but also the form of the metabolites would show it's not a natural one. So the foreign metabolites are what you actually could see. So you know it's not a bioidentical source or an endogenous source made by your testicles.
And since it's not identical, that's what potentially could be causing some of these safety issues with it as well?
100%.
And you had mentioned clotting as one of them?
Clotting, yeah. If you get hormones, estrogen, testosterone orally can affect the clotting mechanism of the liver, which the liver is supposed to do, but it makes it hypercoagulable. I'll give you an example. Women, when they're pregnant, are in a hypercoagulable state because of the high estrogens. So that's why it's important to understand the mechanism. We want to try to bypass the liver, bypass the gut, and try to get in the bloodstream as fast as possible. And that's why the transdermal, or the creams, are beneficial, but they can't reach the same enough levels versus the pellet, which, again, I know I did a little history lesson, but it is when they were thinking, how do we do this in 1935, the first way they thought was the pellet, because it was basically transplanting a pure organ, a testicle or ovary, into the fat. In fact, the original studies on testosterone actually transferring they used roosters first, and they actually transferred into the roosters to see the increase of the cock size, the increase of the muscle go, was to put it under the skin. Same thing with us, Jim. How do you mimic the actual ovary or testicle itself? It's to get into the blood supply as fast as possible by bypassing any detriment like the gut.
Okay, so let's go back and talk a little bit about the creams, since you had mentioned them before. I have a couple of friends of mine that are trying to get them to get on the pellet, but through their provider, they're, I guess, officially diagnosed with low testosterone, so insurance picks it up and they're able to get the cream reimbursed.
Okay, there's 2 types of cream, Jim. There's the bioidentical cream, and then there's the prescription one. The one, the androgel, that's been actually shown to increase blood clots. Rare, but it's been increased blood clots. Don't care if it's covered by insurance or not. And they don't get to the level. The level is not what increases the blood clot. It's the metabolites that increase the blood clot, not the shot. There's a protein within platelets called thromboxane A2, and that causes platelets to coagulate together. And that's actually increased with the injections, the IM, and the androgels. Extremely rare. Bioidentical creams don't have those fillers in there, and they don't have those increased risks, but they don't equal the blood level, the actual blood level that a pellet can. Mm-hmm. But I think creams are the second best.
Okay, and obviously with the cream,
the problem again, Joe, is.
Go ahead.
Is the absorption area, the site, becomes less efficient over time. You could rub it on your kids. You could rub it on your spouse. It could be spread that way. You could put all this money and stuff on your creams. Next thing you know, sweat it off. The goal is to get, the reason why it makes the pellet so great, Jim, it just mimics our body.
Mm-hmm. And obviously the creams are absorbed by the skin, go right into the bloodstream, and you're bypassing, obviously, the liver and the GI tract and so on and so forth. Yeah, but I do, to your point earlier about, it being transferable to, other humans that you're in close contact with. In addition to that, my friends have mentioned that, they have to put it on, they have to wait, it's got to dry. They can't, go work out right afterwards. They can't take a shower. They got to be careful if they, use a towel to wipe the site, so to speak. And it seems to me they're doing it every day. I mean, is that how a lot of these creams work?
Yes, sir. Mm-hmm. Because again, the blood level's not high enough, not constant enough, so you got to make sure you keep them as high as you possibly can. Dr. Amit, our compound pharmacist, he makes a great testosterone cream. It gets good volumes, but the problem is, he'll tell you himself, he's on this, the benefits of how high we get and how constantly we stay level with testosterone pellets is what makes it there. It's just, when I went into this, 14, 15 years ago, I had the plethora of the opportunity to do anything I wanted to do in testosterone. I first recognized we have a testosterone epidemic. That was a given. Then the question is, what is the best route? So I spent 18 months looking for the best route. Yes, a shot once every couple, and I think the shots, they spread out too far, but once a week to every other week, creams every day, every other day. There are options out there. But I was trying to do, what can we do to mimic the testicle exact best way? And the funny thing is, the old best way happened to be the old best way for a reason, because it's worked. There's a great book called Testosterone out of Germany. It's about 800 pages, and the book's premise is to show the benefits of testosterone, this is in men, and how it does. It's 800 pages. And then to show why shots are superior. But even in their the treatment chapter on treatment, they said there's no doubt pharmacokinetically the pellet is the best, but there's a 12.7% expulsion rate. So we're trying to mimic the pellet. So I thought if we could decrease the expulsion rate, then you get the best, plus it's done every 4 to 6 months, and you don't have to deal with everything else. You get the benefit without, a 3-minute procedure, and that's it.
So let's talk about the shots. Where do you actually inject on the body? I'm always curious about that. Is it going into the arm? Is it going into the muscle like the vaccine? Is it going into the buttock area like the pellets do? Yeah,
it's called intramuscular. You want to get it into the large muscle. It's the buttocks or the quadricep are the two most ones. Then it sits there. So if you picture A plus B, we'll call A the testosterone, the 17-beta testosterone. So in the shots, the testosterone is bioidentical. Okay, 17-beta testosterone. Then it's bound to an ester. An ester is an organic molecule. It's bound with this carbon and oxygen. And then there's 3 of them. There's one called ethyrene, propionate, and cyprinate. Those are the 3 most common. And when the ester dissolves, that's how it leaks out of the muscle into the blood. But the half-life has to do with how that ester works. Propionate propionate's the fastest, enthrane's the second, cyprinate's in between those. So, but you still get these peaks and valleys. I've never had the injection, Jim, but we've had one person in 11 years go from injections to pellets back to injections. Mm-hmm. So that to me tells me a lot of stuff. There are some studies that show the pharmacokinetics of a sub-Q smaller needle is equivalent to the intramuscular. It's not standard, but the studies show that way. But again, you're injecting yourself every couple times a week. I want to be very clear. If you have low testosterone by today's standards and you want to get to other standards and you do shots or creams, I'm ecstatic because you're helping yourself. But the bottom line is the studies show to get heart and brain protection, you want a consistent non-peak and valley, and you want to be over 700 for the heart and about 1,000 for the brain. And again, the pellet shows that data because it's a consistent, steady release. The pellet, a 200 milligram pellet, releases 1.7 milligrams per pellet per day on a constant, steady state. So it's hard to say anything's equal to that because they're not, but they're better than nothing.
So to digress a little bit, let's talk about the heart and the brain. You just made an interesting comment, and the way I'm interpreting that comment is there's peaks and valleys with the testosterone levels, and therefore, if you're the heart or the brain, you're not getting what you need, or maybe these organs are reacting in a way where due to confusion or what have you. Why is that so important?
Because testosterone is very important for mitochondrial health, which turns oxygen to energy. The heart is 35% mitochondria by weight. What does that mean, Greg? You guys watch movies and you see cyanide poisoning. Cyanide works on mitochondria that fast. So that's why cyanide attacks the mitochondria. So testosterone helps increase mitochondrial growth. Actually, it's actually made there, and the efficiency of making oxygen to energy. And again, the heart's 35% by weight, and the brain's roughly 50% by weight. That's one thing. It's the energy source for those two organs to work properly. The big one, Jim, a lot of the literature now we're reading with PTSD and TBI, and I'm talking to some great guys with Human Performance Labs, is that it's insulin. Hyperinsulinemia. Insulin that small peptide is actually used as a transmitter in the brain. But when you get really, really high, it shuts off its function. So the high glucose in our body leads to high insulinemia, which then does let the brain talk to each other. And we're finding, there's a lot, not we, but the studies I'm reading, that with optimal testosterone level associated with optimal growth hormone levels, that the hyperinsulinemia decreases, therefore the hyperglucose decreases, and you have more insulin sensitivity that's what testosterone does, the cells could function more appropriately. Picture it this way, Jim. I'm sure a lot of our listeners have heard about hemoglobin A1C. So blood cells float around the body. When you have extra sugar floating around the blood, your body has to do something with it. It's a very sticky substance. So it sticks. One thing that sticks to is red blood cells. So that's why how bad your sugar is how your hemoglobin A1C is. You want under 5.5%. Well, that glucose molecule sticks to every protein, not just red blood cells. And the big one, it's the neurons in the brain. That's why Alzheimer's is called type 3 diabetes, because it distorts and tangles the neurons. So it's not just a hyperinsulinemia event, it's also a structural 3D event. So that's why these hormones are very crucially important to make the brain and heart work optimally.
So what's better for the brain and the heart? A person who's got low testosterone that is stable and it's just low, so that person averages 200 to 220 and that's it. Or somebody who is at 220, gets the shots, they go to 1,000, let's say, then they drop back down to 600, they get a shot, they go to 1,000. So it's all this constant up and down. The roller coaster is far superior. Is it? Okay. All right. That's what I wanted to know. So no matter what. Because you're getting, no matter what. Okay. No matter what. We've seen that. In fact, we're working with that Human Performance, one of our guys, and he's done shots forever, and he converted the pellets, and he said he's not slept in 15 years, and he slept in the first 3 days. So because it's the constant steady state, but it's still better. When he started testosterone, he was a zombie, his own words. Starting the shots improved. But the route changed that month that after being on shots for about 10, 12 years, he literally slept within a week, 3 nights in a row. He called me, he could not believe it. Okay, so now we get to the pellet. I know you've been trying to get there for the last 18 minutes or so, and now we're here. So from my perspective, being a patient, I come in, I get the procedure done. To your point, it's a 5-minute procedure. And then I'm pretty much good to go for the next 6 months. So from a convenience standpoint, it's far superior. I'm not taking shots every week or 10 days or whatever the time frame is. Obviously far superior to the creams as well. And so from that standpoint, it's great. The downside to it is that, you are breaking skin and, you are, placing the pellets. And you're at the placement site, there tends to be some sensitivity and what have you. So before we get into your technique, let's just talk about in a little more, I guess, detail, the practice of placing the pellets. And then once that pellet is inside your body, how is it able to slow release and keep those levels the same, for the next 4 or 5 or 6 months compared to the shot?
Beautiful. First thing is, we'll go to the pellet. We're talking only men pellets right now. The men pellet standard size is 4 millimeters by 12 millimeters. Based upon your size, your levels, men get between 7 and 11 or 12 of those. Again, the pellet is squared off. It's a round with a squared off. I was a pelvic surgeon for years, and when I operated laparoscopy-wise, my probes I used to get into the body, after I got in the body with the sharp, what's called the trocar, I used a rounded blunt dissector. And I used water or normal saline to dissect my tissue, because there's a lot of planes within the body that are avascular. So you think you stick a knife in a belly, everything's going to bleed. Not necessarily. I mean, there's ways to get around and make surgery as bloodless as possible. So when I saw I looked at the probe we were using, and I saw a company that had a roundish one, and I talked to our company, Qualgen, and I said, I got an idea to make it this kind of shape. And they took a year to do it. They made a shape for that because, again, when you're pushing the pellet in, that's a cylinder with round 90-degree angles, you're going to cut tissue, more chance of cutting tissue. The rounded edges separate tissue. Also, the technique I use is I use the saline, the lidocaine, 2% lidocaine with epi and sodium bicarbs is less burning, but the actual injection into the subcutaneous area separates the tissue prior to even place it. By using the needle and spreading about 120-degree angle, I could actually separate the fat area more to have a space for the trocar to go. Then, I jumped into that. So the pellet itself, how it goes that. And we know from the original, multiple studies now, but that size pellet, again, without heart rate staying stable, not working out, it's 1.7 milligrams per pellet per day. So you put 10 in there, 10 times 1.7 is 17 milligrams per day. You're releasing into your bloodstream. So it's a steady state up. It peaks about 1 month out, and then you lose at 1.7 per day very slowly. Now, you work out, you get a heart rate goes faster, because it's the actual physical structure of the pellet leads to its route. Because it sits there, it's compact, pure testosterone. When the blood overflows it, just the top surface secretes. Just onto the blood, because an endocrine gland does not squirt testosterone from, say, the testicle to the brain. What it does is it releases it into the bloodstream around the testicle, into the bloodstream. The bloodstream goes through the whole body, and the cells that have receptors grabbing it. That's how it works. So the pellet actually mimics that by sitting in fat, because fat may not look like, but it's very vascular with these small capillaries at a microscopic level. So it's the structure of the pellet, Jim.
So if you're working out and you're keeping your heart rate up on a regular basis, does that shorten the pellet efficacy, or does it actually lengthen it?
It shortens it, but you get the benefit because when you're working out, you get a rise. So you get a rise during your workout. So you have a steady state. You're at a great level, 100, 1100, whatever you are. In your workout, you're getting release bumps, just like you would if you're doing deadlifts or working out with your normal, if your body's working functionally. So your duration will be shorter because you may go through it. I'd much rather, get pellets every 5 months and be optimal than to not work out at all, make it last 9 months. You'll get benefit from that, but you're not going to get the benefit your body's going to get by working out.
So when you say when you increase your heart rate, you're actually, manufacturing more, your body's manufacturing more testosterone?
No. The bloodstream is making a faster current over the pellet, so it's taking more pellet off
I see.
Like a sandcastle, okay. Right? If you got a sandcastle, a little bit of water comes, wash a little bit at a time. One big wave wipes out most of it. So your workout, not a wave, but it's bigger. So you're not making more of yourself. You're releasing more of the pellet there because there's more blood going to washing off the top layer.
Got it. Okay. That's a good analogy. All right, so you, again, jumped a little bit ahead. This seems to be the theme today, but so you're initially...
Just today?
You're initially doing the placements in people, and you talked earlier about the squared off corners, on the pellet, and, the old technique, is more sharp, and you're in effect tearing or breaking tissue, as you're doing this, and therefore the patient at the end of the day experiences swelling and potentially some discomfort, and potentially a pellet being expelled, within the first, 3 or 4 weeks of placement. So you're going through this thing, you're doing this thing for a few years. What motivated you, or was there a specific instance with a patient that the light bulb went off of your head and said, you know what, I got a better idea to do this?
I happen to be an OBGYN, so I'm a pelvic surgeon, not a orthopedic pelvic surgeon, but an OBGYN pelvic surgeon. So I know the anatomy pretty well. And the way everybody's trained is a certain way. You go, everybody treats. You go lateral to the sciatic nerve. That's not even a question. Everybody does that. But the space we're trained to go up is a little up and outer quadrant of your buttocks outer. So if you could put your finger on your iliac crest on the outside there, that right there is go down under your belt line and go up to that area. And it works. There's nothing wrong with that. Again, the national average of pellet loss is about between 5 and 7%. We were about 3% range, but I found I was more tender. And then, so the first thing we did, we added ice immediately. The ice, we have found these wonderful round ice packs, just changed everything because inflammation the first few hours made a world difference. The round pellet helped. That helped again. That was about 4 years ago as well. But there's a space. If you fill the back of your iliac crest again from the middle of your spine to the side, there are two muscles there. The biggest one is the gluteus maximus on the medial to the medial side, the middle to the outside, and then one called the gluteus medius, which is more lateral. And if you look at the butt and the crack in the middle, so it's about 2/3 of the way out to the lateral side, there's a space between those two. And I thought, wow, why not put it there? So let's aim. So I go from where the belt line is, go about 2 inches under that, and then I look at that and I aim for the femoral head, the head of the femur in your head. There's like a pie there, pizza pie right there, from smaller to larger. And we numb that area. And we just found I think it's a combination of the hydrodissection, a combination of the pellet shape, and also the combination of our speed. I do a woman in about 30 seconds, the actual placement, a man about 2-3 minutes. And I was taught as a surgeon, speed's very important, not to be fast, but it's less trauma to the individual if you do. Smoothness leads to speed, not speed leads to procedure. And I found knowing these landmarks, I think it's very teachable. I used to teach surgery years ago, and knowing landmarks really helps, Jim. And we have 4 or 5 wonderful nurse practitioner PAs here, and they've learned the technique. And what's very interesting, Jim, when other people come to us from other places and we're done, they can't believe we're done. They can't believe the procedure's done, which is great. I think it's awesome. I thought I sort of pioneered that position. I did not. I found a paper from Dr. Morgenthaler that he actually did that technique. I may have modified it a little bit more lateral, but it was not my technique. But I do believe we've sort of pioneered with the combination of the pellet, the hydrodissection, and the area I'm aiming to. And then the reproducibility of it, Jim. That's what's important. You don't need Dr. Brannon to place your pellets. I think our Optimal Bio way is transferable.
The Trocar. Explain what that is to us non-medical professionals.
Okay, and the pellets.
No, not the pellets. The Trocar itself.
No.
And then.
No, I'm going to tell you.
Okay. And then the
pellets. Oh.
And then you had mentioned before you're using a duller Trocar now than the sharper Trocar.
Right. So a Trocar, picture it as a metal straw. Okay? You got the butt end where you load the pellets and the shaft that goes into the underskin. It goes about a 30-degree angle under the skin. Under the skin, above the muscle, there's a space of subcutaneous fat. That's what we're going for. And so we dissect it off with the fluid, we open the space up, and then we make a 3-millimeter incision. And the pellet's 4 millimeters. That's the diameter of the pellet. The Trocar is about 4.1 millimeters inside, the inside diameter. So we use what's called an 11-blade scalpel, which is like a point. It's a sharp point. You make a stab incision 3 millimeters. So then I put the skin in, back to my surgical technique, and when you place what's called a trocar for laparoscopic surgery, you put pressure on it, but you rotate to separate the tissue again. So we do the same exact technique. We don't just push it in. So doing that, we do have the sharper edge of the trocar as a beveled edge, but we don't, I use a blunt probe inside there, so I'm not cutting as much tissue, so I'm actually separating it with the rotation. So I'm keeping constant, steady pressure with the back of with my palm as I rotate it at about a 30-degree angle, and that separates it. Then you pull out the blunt one and you put the pellets in, and then there's usually 3 rows. So I put a row in the middle. Then since it's a 45-degree bevel edge, I roll it to left side and then move it out so that you keep the pellets separate, 3 separate rows. Because the worst case is when they coalesce and form what's called the seroma. The seroma builds up pressure, and they could push the pellet out through the track and out, which our rate's now under 1%. But that can happen. Usually, people don't listen. I want no deadlifts or squats for about 4 or 5 days for the men and continue the ice. A woman losing a pellet's less than 1 in 1,000.
Okay, I think I understand what you're doing there. And
So it's just a picture of straw at a 30-degree angle to the skin going into that area. So now I got a straw in there. And in the straw is where I put the spitballs, where, kids, whatever. That's you put the pellets inside there. And then if the shaft of the trocar is about 4 inches, so the pellets are going to be at least 4 inches from the skin incision. So they're about 6 inches away from the skin incision, and they're far away because when they get closer, that's how they can migrate up the track. And the hope is, and there's your other technique, Jim, is we compress that. So hopefully actually completely compress that track immediately. We put a Steri-Strip and a Tegaderm over, which is waterproof. Then we put some paper tape and put pressure dressing to compress, not to compress the pellets, compress the track so that the tissue could get, there's no dead space in surgical fields, and then put ice pack over that. So the tight pressure bandage, only for an hour or two, really makes a difference in compressing the track loss too. So I think all that adds up, Jim.
in the actual, if I was to look at a pellet, or you describe the pellet to people on this podcast, because when they're getting placed, they're laying on their stomach or on their side, so they can't see the pellet. What's it look like?
Right. Yeah, it's a grain of rice is more of the woman's dosage. It's the 100 milligram pellet is 3 millimeters by 10, but the estrogen pellets are like wafer thin. So very small. So that's correct. But a man, picture, 12 millimeters. So half an inch, a little over half an inch in length, and 4 millimeters in diameter. It's a pretty good size. Mm-hmm. Ours are made from cholesterol as the binding agent. They have a nice smooth surface on them, and they're not encapsulated. It's the same hormone through and through. That's why it dissolves. The top layer, like the inside layer, is exactly the same. So, okay, I'll give you a skinny, a good and plenty. A skinny, good and plenty.
Candy from the past.
The oldest candy in American history, which I love too, but that's another story.
So you had a recent experience with a patient of Optimal Bios in Charlottesville, Virginia. And just for those listening for the first time, Optimal Bios experienced significant growth over the last few years, and we ended up acquiring a practice in Charlottesville, Virginia, back in June of 2021. And that patient that was as part of that practice was going to a different doctor who was using a different technique. Tell us about that patient experience after you placed that individual a month or so ago. Yeah,
we had a great conversation over the science of it. It was fantastic. She enjoyed us talking about that. So you lay on the side and you tilt just a little bit, so it's not on your belly, a little bit on your side. And so I use a technique where I use iodine alcohol to sterilize it. Then I numbed her and placed the procedure. Again, a woman's rather quick. The actual, say she's on her side probably 30 to 45 seconds. And I go, I'm done. She goes, nah, you're kidding. I go, I'm done. And she goes, I've never been fat longer. I've never been here less than 20 minutes. And I said, okay, I'm just telling you. And she literally went home the next day, felt no pain, nothing, emailed us and said, are you sure you put it in there? Because I've never had this experience. And I was like, all I can tell you is we did it. We'll check your labs in a month. But and that's not unusual, which is weird, Jim, because the unusual part was she didn't believe us face and email. But it is, again, we've had people go to other places and say they had not that kind of experience. So it's I think the technique is definitely reproducible, Jim. Because again, same thing with our PAs, Jim. We've been all placed by our PAs. Every PA has to place me first. And again, I think that the education is my job to teach the technique. But yeah, she didn't believe it. I think she finally believed it. We'll see how she's feeling. But that was very unique. The email was very funny.
Well, I mean, just from my personal experience, having been doing this for a little bit over 3 years right now. The last, year and a half compared to the first year and a half, post-placement is night and day. I mean, there are times where if I weren't getting that Novocaine shot to numb things up initially, I wouldn't even know you're doing it. And, by 24 hours to 48 hours later, you just have this little bump there and that's it. It's nothing like it was before.
Yep.
So for those out there that are going to different doctors to get the pellets right now, you might want to consider Optimal Bio because, like I said, Dr. Brannon's got a very unique technique, and our PAs have the same technique, and the efficacy and the post placement discomfort is very little for most. Anything else you want to talk about in reference to BHRT?
Other than I think the importance of it for our overall health is so strong. So what I want people to do, and hopefully we educate, is to start reading on the health benefits of being optimal. Okay? How the way they sell the commercials, they'll say, she'll love it too and that kind of stuff. No, that's not what this is about, Jim. It's about wellness and health. And I don't want to play a game. This is not a game. It's like, Frederick Douglass and Davy Crockett ran around 1400. Why aren't we doing that? And that's what's important to me is, we have these hormone standards, and if they're changing, the question should be why they're changing, not that today's values are better. If they happen to be, fine, but they're not. When your body's making less of what it's supposed to make, that cannot be beneficial. That's be detrimental. So really understand the health benefits to bone, to heart, to brain, to other hormone systems, to the way the brain works, the anxiety, depression. We have so much. We have about 70 articles in our book dying to this right now. And Jim, working on another book to show in pure science on the benefits. Is look at the science benefits and then find the best route of administration. If anybody's on hormones, I'm ecstatic because they're searching out. And I think that's what I really wanted to do is help them understand that there are ways to get this done and you're healthier. No, you're not paying a price. You're not getting fit for a shorter time. Longevity and health go together. They're not concurrent. They're actually concurrent.
Yeah, and since I've been involved here too, it seems like the lab ranges are going down every single year. And I know in previous podcasts we've talked about, the disruptors, in our diet, in our plastics and everything else, and it seems like nobody anywhere is doing anything about it at this point in time. So, there's going to be a greater dependency, I think, on testosterone treatment and hormone treatment in general in the future, unless things change from an environmental standpoint.
Yeah, it's starting in the womb, Jim. We have generations we can change this around. Just take generations.
All right, so let's pivot a little bit. I kind of want to go through a little brief discussion on peptides and CJC. So just for myself and for the audience, what are peptides? And I think insulin's probably the most famous one at this point in time?
Exactly. A peptide, when you have two amino acids that bind together, that's a peptide, a dipeptide, a protein, different names for different structures. But we use peptides as usually a small molecular protein. Insulin is one of the most common peptide we know about. That's correct, Jim. So it's a protein that has functions. So that's what a peptide is. And you said insulin is the first ones found and the first one we actually understand. It's made by the beta cells of the pancreas, which causes your body to store glucose into the cells. So after you eat, your body makes insulin. Insulin makes this neurotransmitter to the cells. Cells understand the reception of the information, and then opens up the receptor site to put sugar into the cell and store it as fat.
So from a simple way, the way I understand it, every day your cells are reproducing, they're getting broken, they're getting banged up. You go to sleep at night, hopefully you get a really good sleep, and that gives you the chance for your body to fix, to drain, to replenish itself, to fix some of these cells and what have you. And when that doesn't happen, I guess when that does happen, you're trying to get into a homeostasis place, basically. And when you're not, you're in a senescence place. I think I got that right. So you want to talk a little bit about both of those real quick?
The homeostasis is when you're healthy, senescence is when you're aging, right? So the goal is, why do we age? Multiple theories. Do we age because we lose hormones, or we age because we don't have hormones? Do we age because there's abnormal proteins? All these things add together. So a cell's happy when you picture a growth hormone, we're going to talk about next. Growth hormone makes cells stay happy and young. Has multiple functions on not just muscle and fat. It also puts us in the deep sleep wave. It actually makes the body heal when we're sleeping, like you talked about. So what we're talking about with peptides is we're looking, how can we augment what our body makes? Every single hormone we make decreases with age, except for cortisol. And cortisol stores belly fat, makes cells weaker. You cut your skin, you're bruising. That's all hypercortisol. So the goal is, can we mimic, and there's controversy on this, but not much controversy on IGF-1 and functioning with age. So the brain, part called the hypothalamus, has these 6 hormones. We're going to focus on this one right now called releasing hormone, growth hormone releasing hormone. Growth hormone is secreted every 90 minutes, lasting for about 2 hours. And the frequency doesn't change with age, but the amplitude does. The largest amplitude is before sleep, because growth hormone peaks about an hour after deep sleep. So that's growth hormone releasing hormone. Makes your anterior pituitary release growth hormone in the cycle I just talked about. Then growth hormone tells the liver make a thing called IGF-1, insulin growth factor 1. Sounds bad, insulin, but insulin growth factor, insulin's other functions to make cells grow, to heal, to not be sensitive, like you talked about. Then the IGF-1 just wants something else. It makes a thing called somatostatin, which turns it off. So you have this great cycle. So there are 3 things that control the production of growth hormone. One is somatostatin, which turns it off. Then you have growth hormone, releasing hormone we talked about. And then you have the things called growth hormone peptides. They're called growth hormone secretories. It's a granulin makes you hungry, actually augments this as well through a completely different receptor site. So that's how the body works normally, okay? So the question is, how do we augment our testosterone? Since growth hormone, insulin growth factor uses testosterone and optimal thyroid, how can we get those things, or we lose those levels with age? And again, this is important. This is not anti-aging. It's not fighting age. It's being optimally healthy. The growth hormone releasing hormone is this peptide that's 44 amino acids long. Well, they know from what's called the amide, the terminal end of the nitrogen and hydrogen end, those 29 is the active part. And there's a few out there that actually mimic that. Sermorelin is one of them. There's another one called CJC 1295 without DAC. The reason why I like that one, Jim, it doesn't affect prolactin or cortisol growth. It doesn't have any side effects on other releasing hormones. So that makes your own go up. And then impemorelimine is what's called a ghrelin hormone releasing peptide that mimics ghrelin, that works by another way to augment your growth hormone by turning off the somatostatin for just a short time, so you get the benefits without losing that circle of turning yourself off. So our levels, if you do it this way, is you never get super physiological levels. You only get optimal levels as our age gets older.
Is there a difference between a typical HGH and an HGH peptide?
Yes. HGH is human growth hormone. Again, it's great. But if you take it by itself, you lose that feedback loop. So if you get dosed properly, it's okay. But you can increase blood sugar, hypertension, carpal tunnel syndrome. But if you do the growth hormone releasing hormone analog, you don't lose that feedback loop. So you don't get those side effects. And you get the benefits you talked about. Promote slow wave sleep, improve memory retention, stimulate muscle growth, which sounds crazy, but Jim, number 4 cause of death over the age of 60 is falling down, usually falling down off the toilet. Sarcopenia means you're losing muscle, and we lose 1% of muscle every year. What if we could stop that? We'd lose these other diseases, and the 4th thing it does is burns fat and makes lean muscle, which is, again, it's healthy for you. It's not just a physique thing.
Okay, so you mentioned that if HGH is dosed right, less side effects.
Exactly.
But from the peptide HGH, is that just a dosing issue with HGH, or is there a difference with the peptide HGH?
Yeah, there's a difference, Jim. Because if you take growth hormone, releasing hormone, again, all it's going to do, it's going to augment your normal release of your normal growth hormone. All right? So you can't go higher doses. So therefore, you will not have the hyperinsulinemia, you will not have the high blood sugar, you will not have the carpal tunnel, you will not have those issues because it also downregulates itself. That's what's important. Growth hormone, in fact, in America, you can't take it. It's a black box thing. You can't even take it unless you have syndromes of complete deficiency of that growth hormone, which is a problem because there's a lot of benefits to it. With, again, think about the brain with PTSD and TBI. The cutting edge in the future is going to be growth hormone, releasing hormones, testosterone, fish oil. These kind of things are making the brain work much more efficiently. So the thing we're going to do is I want to mimic, because it goes back to our bioidentical premise. This is, the 29 end of it is bioidentical, but it is, I want to mimic what your body does. So I don't want to make more physiological levels. But I'm not here to poo-poo growth hormone, Jim. If you got the right dosage, you could fine-tune it, and you have to take times off of it so you don't turn off your hypopituitary axis so that can regenerate itself. But when you go on growth hormone-releasing hormones and those augmented peptides, you don't ever lose that downregulation.
So how would you determine whether or not a patient needs growth hormone?
Yeah, there's a thing called adult growth hormone deficiency syndrome, which has to do with symptoms, sarcopenia, loss of muscle, loss of bone. But the problem is that's a normal variant to everybody. So when you look at the strict criteria, the problem is that very few would meet the strict criteria because everybody's losing that. So when you look at symptoms. The biggest one, Jim, is sleep. It's sleep. It's recovery from sleep. What it does on the slow delta waves is tremendous. So sleep's the big one. Joint pain, recovery. But again, testosterone will help most those, if not all those. But it's fine-tuning what you need to do. And if your brain is really one involved, that's where the growth. We've been very fortunate. You working with our military with PTSD and TBI clinic, we have been referred, and they see a significant difference when you augment them. It goes back to what we talked about a half hour ago, the insulin again, because the insulin growth factor fine-tunes it so you don't get hyperinsulinemia. You don't have those issues. So sleep is the number one thing, Jim. That's the one I can't stress enough.
So tell me about CJC then.
So back to our growth hormone releasing. For each of these, there's two things. There's growth hormone releasing hormone, and there's growth hormone releasing peptide. Okay, that's made in our gut called ghrelin. Okay, that's in our gut ghrelin. So they made analogs of that. Imaporolamine is one of them. It's a pentapeptide, 5 amino acids that augments CJC 1295 without DAC. So again, growth hormone, releasing hormone itself is 44, but the 29 at the end is the one that's active. So they substituted 4 amino acids and made CJC that molecule. So that one augments the release of its own growth hormone. That's how it works. So you take those two together before bedtime. You can take a morning dose and afternoon dose, but the bedtime one's the optimal one, and that will help put you to sleep. And then when you're sleeping, your body's recovering. So the word eugenesis you're doing will be less of that. So the cells will be able to help to grow and prepare themselves. The key is repair.
And how do you take it? Is it an oral?
It's an injection. It's a small needle, 31 gauge, a diabetic needle, and you rotate it on the skin around your belly and sides. Monday through Friday. You just want to rotate it. I like 5 days on, 2 days off for 3 months, and then 1 month off. There's no studies to show that this continuously will turn down your brain, but the studies up to a year being on this has seen that if you do that, you never turn down your hypopituitary axis.
So Dr. Seed is one of the doctors, I guess, on the forefront of peptides at this point in time, and she talked a little bit about being able to help a female who had chronic myeloid leukemia who was, trying to get pregnant. She talked about it potentially being beneficial to, certain types of arthritises and what have you. From a very simplistic way, is the peptide in general, kind of like the EMT or the first aid station that's coming to the cell to help protect and help fix, what's going on?
Yeah, that's a good way to say it, Jim. Dr. Seeds was an orthopedic surgeon, so he understands how the body works. It has to do with growth hormone heals, period. It heals, okay? When you and I were kids, if athletes went to Germany to get healed, they're going there for that in those days. So that's why the combination of lowering your sugar, increasing your testosterone, increasing your growth hormone have all been shown to be beneficial for healing. Brain first, we'll say the musculoskeletal stuff second. So when you look at arthritis, that's an inflammatory process, right? So you want to heal the cartilage and heal the bone. And he talks about in his book, he's had patients in the old days, he would have done maybe some, missed this surgery he's not doing surgery on. It's not the end all, the be all. If you're bone on bone, he's the pro at that, not me. But yeah, this growth hormone's a healer, Jim.
Okay. In your practice, have you run across patients where you've had to recommend, potential growth hormone treatment?
Yes, Jim. A lot of our military. We have a lot of referrals from counselors, psychologists, psychiatrists, PTSD clinics. I find that they talk to me that the testosterone's phenomenal. When they add the growth hormone, it's a game changer. That's who it is. The literature, Dr. Lungo at USC is a big believer in low IGF-1 increases longevity. But you look at his data, it may be blue zone areas that may be a little skewed. Seeds goes through that in detail in his book, showing just the opposite. Almost everybody shows IGF-1 actually increases quality and longevity. So I don't be poo-pooing. There's not some controversy there, but Seeds has some great literature on that. So, but I think as we age, I've been on myself for 6 years, Jim, and the biggest thing I find is that with our pellets, it's sleeping 7.5, 8 hours and wake up with no alarm for the last, I was an OBGYN for 30-something years. The last 5, 6 years sleeping like that has been just a life sin.
Sounds good. Anything else you want to add on CJC, peptides?
And I think it's important, if people come to us, Jim, we give them like Seeds book to buy. We give him other articles to read. It goes back to education again, Jim. And we're not here to argue with other doctors. I mean, I'm an allopathic. I get every diploma on the wall in my office. I got all that. But I'm also board certified and a fellow in functional and metabolic medicine. It's just in medicine in America, we're trained so illiterately in nutrition. And I think that's why it's important for the individual to be the best advocates themselves. So I think Optimal Bio, our job is to educate, Jim. So my last thing always, Jim, is that I want people to take their life is more important to them than anybody else. And I hope we can help them walk that path.
All right. As always, we end with takeaways. I know you already gave a few, but can you come up with 3 or 4 more takeaways you want to leave the audience with tonight?
Don't take something that's common makes it normal. I don't want to hear normal is actually okay. I think it's really that. And the third one will be, Jim, ask questions.
So just real quick, elaborate on the normal is okay thing.
I go to my doctor, I feel tired, and they say it's normal because you're 50. My wife comes, she's 35, she has 3 kids, she's tired, she has no libido. It's normal. I hate hearing that. I don't want to hear normal. And then when you start looking at the data more detailed, Jim, and then that's the question was, okay, if that's it, like how many doctors even check women's testosterone levels? You know what I mean? Because in America, there's not recommended even treat them for testosterone, let alone, 40, 50 years ago was 150 to 200. Now it's 3. Well, why wouldn't we test? So that's why it's important, Jim. Just because we have a little picture in our office. It's as a woman passed out on the floor, and there's a range there, it's a scale, and it says, the doctor says, well, you're within range, and she's, 1 point above range. And that's why those ranges, where's that data come from, Jim? And if you check 10,000 sick people, you're gonna have a median, you could have a standard deviation, you have a bell curve, but they're all sick. So that's why I love Jim. Everybody that comes back to us a month later, I say, grade us. We are a 0 out of 10 in your life. What are we now? And then it may be a 5, it may be a 6, it may be a 3, whatever it is, we want to know. And then we can fine tune those because the numbers are our guidepost. How they feel and their health is what dictates everything.
Sure. And just for the record, we talked a lot tonight about testosterone in males, but Optimal Bio actually treats about 55% of his patients are females. Just want to put that out there as well. As always, thank you for your time tonight. It was very informative. And anybody out there that wants to learn more, we have a podcast library on our website, optimalbio.com. Feel free to listen at your pleasure, and we hope to see you at the practice at some point in time. Take care. Thank you.
Thank you, guys. I appreciate it.
This has been a production of Optimal Bio. Optimal Bio is CEO Tyler Brannon, podcast host and partner Jim Baker, medical director Greg Brannon, production assistance by Core Media, Beth Gravencourt, administrator, Kevin Duthu, executive producer. The podcast can be found on our website, optimalbio.com, on Apple Podcasts and Spotify. Our theme song is Sunwave by Paradiso, provided by Epidemic Sound.